Hi guys, I'm Danae. I'm a doctor with a background in public health, and we're joined today by a friend of ours, Christiana, who is a pharmacist, and I'll let her kind of give her own introduction.
Hi everyone, I am Christiana and I work as a pharmacist in the NHS. I am an antimicrobial slash infectious diseases and HIV pharmacist. So, yes, this is why I'm here today to answer some of your questions.
Awesome. Well, thank you so much for joining us and taking the time. I know I sat down and thought about some of the common questions, and today we're going to talk a bit about PEP and PrEP. So, the pre-exposure prophylaxis for HIV and then the post-exposure prophylaxis. And so we kind of assembled a list of common questions, at least questions that I know I get asked a lot when I'm working, and I'm sure you get asked all the time. And so we're just going to run through. So the first question about PrEP is, what is PrEP?
So PrEP essentially is pre-exposure prophylaxis. It's something that we recommend or we give out to certain groups of people who are at an increased risk of acquiring HIV. So essentially, we're trying to prevent them from getting HIV. If we know that they engage in certain types of behaviors that can be risky, then we give them PrEP so that they don't get HIV.
Okay, fantastic. And PrEP is just a pill, is that right?
Yes, it is a tablet, yes.
Okay, fantastic. And so we know that people would take PrEP prophylactically, right? So to prevent acquiring HIV. But can anyone take PrEP, or is it just specific groups of people who can take it?
Um, so that's a tricky one. I would say yes and no. When I say anyone can take it, in terms of you could be MSM, which is men that have sex with men. You could be heterosexual. Um, you could be trans. Um, as long as as long as you are at an increased risk of getting HIV, then you would be eligible. So, yes, in terms of everyone in terms of sexual orientation, but no in terms of the behaviors you engage in that could put you at risk. So, if it's a married couple, none of them have HIV. They only have sex between themselves, then they are at very low risk of getting HIV, so they wouldn't necessarily need PrEP. But then if, say, it was a woman or a man who has multiple sexual partners, and they engage in condomless sex, and they don't know the sexual history or the background of the people they're having sex with, then they're at a higher risk of acquiring HIV, and they would be eligible for PrEP. So essentially, there's some eligibility criteria that we sort of follow um, to make sure the patient is suitable for it.
Okay. And I know we'll probably circle back to that at the end. So, because I know also groups of individuals are able to get PrEP on the NHS, whereas others aren't. And so we'll circle back to that at the end.
Yes. Oh, I should also, yeah, that's a good point, actually. So I suppose when you say, can anyone get it, it depends on where you're going to get PrEP from. Because I work in the NHS, my mind only ever thinks about the NHS. So, but I suppose in a private setting, then that would be a discussion between the individual and the practitioner they're seeing, be it a nurse prescriber or pharmacy prescriber or just a doctor, as to if it's appropriate for them. But in the grand scheme of things, I suppose if they're paying for it and they want it, then that's a discussion they would have to have. So in context of the NHS, you would have to fulfill the criteria. If you're outside the NHS, then it's a conversation between the prescriber and the patient, really.
I see. So there are clinicians now outside the NHS that are prescribing PrEP privately. Because I know for a while people were going onto online pharmacies that had that green cross on it, but it meant that it was like a regulated pharmacy, basically. That like I guess the UK, I don't know if it was the the Pharmacological Society, but they kind of had approved. The Royal Society of Pharmacologists, but basically said it was a legitimate pharmacy. So I knew lots of people were going on there to purchase it.
Mm,
before it was being covered by the
mm,
NHS.
mhm,
So that's really, really interesting. That's great to know.
mm.
And so for those who might be eligible to get it on the NHS, I know you mentioned people who engage or who have higher risk. So, for example, people who have sex, men who have sex with men. I'm assuming anybody who is involved in sex work would be eligible on the NHS.
Absolutely, yes, there would be. So there's a list. What I talked about wasn't an exhaustive list. That's just the ones that sort of rolled off on my tongue. But yes, so if they were in sex work, or even if it was a relationship with one person, but one person had HIV and they were not yet undetectable, and they were still having condomless sex, then they would be at increased risk. So there's a number of different scenarios to consider, but we have all the guidance that we need from the NHS. And in a private setting, I suppose that would just be more of a professional judgment between whoever's prescribing it and the patient.
Got you. Okay, very, very cool. So that kind of covers the next question. So, in the UK, how do people access PrEP? And so it sounds like they can either go to an NHS kind of clinic, or they can go to, a private kind of clinic. But let's say they're going through the NHS. Would they just book an appointment at the gum clinic and then speak to a healthcare provider about some of the risk factors to see if they qualify?
So usually, yes, you can go to a sexual health and gum or gum clinic. They're essentially the same thing. Um, yes, and then booking appointments. Sometimes it might be first of all a telephone appointment, just because initially everything was walk in, and then COVID came, and then we had to readjust. So a lot of times, through a telephone booking system, and we might have the initial conversation over the phone, and then if depending on what the outcome of the conversation is, then they would come into clinic. When you do come into clinic, then you would sort of go into a bit more depth about what it is, what it does, what the risks are. Like in terms of risk, we're talking about side effects, but the benefits are. You also obviously will talk about the importance of regular STI checks and just any sort of general public health messages you want to pass on. You'd obviously do a full consultation, check their background, previous medical history, family history, social history, any drug, any medication they're also on, allergies, all of that, like a typical consultation. And then if it's suitable, then you can proceed to say, okay, yes, the patient can have it. It's also worth mentioning that when we do go for the consultation, you would always do a HIV test, because we always want to make sure that the patient doesn't have HIV at the point of starting PrEP, because if they do, then giving them PrEP while they have HIV can cause resistance.
Oh,
And the other thing is that because with PrEP, it's just two drugs, um, whereas if we're actually treating an active HIV infection, in most cases, it's a triple drug regimen. So you'd always have to exclude the HIV infection and any other sexually transmitted infections like syphilis, gonorrhea, hepatitis, and so on. So you would have to do the full workup. And the British HIV Association and British Association of Sexual Health, uh, the second H stands for BASH, they have a full guideline, and they tell you what to test and what to do before you start PrEP.
amazing. So basically, if somebody, so they may have their first consultation over the phone to see if they're eligible, and then they
Mm-hmm.
might go into a gum clinic and have a
Mm-hmm.
consultation with the healthcare provider again in a bit more depth about what PrEP is and get a full
Mm-hmm.
STI screen and workup to make sure that they don't have any pre existing STIs before they
Mm-hmm.
started. I didn't realize that actually it would cause, but it makes sense that it would actually cause resistance if somebody was HIV positive unknowingly and started
Mm,
PrEP. That makes a lot of sense. Yeah.
it would, because especially with the retrovirus, because they can adapt very, very quickly, and that's the basis for the triple regimen in the first place. Anyway, the other thing as well to consider is that if somebody does have HIV, we would do a baseline resistance test to see what classes of antiretrovirals are suitable for them. So if they do have HIV and you don't test and you give them PrEP, they may already be resistant to that drug and you don't know. Um, you just be wasting your time and the patient's time as well.
Yeah. Oh my goodness. So in the UK, do people need a prescription for PrEP?
Yes, they do. Now, most times, well, you say yes, they do, but most sexual health clinics keep what you call pre-packs. So we've already contacted the manufacturer and the supplier to say, um, p- give us a 30-day pack of the drugs we use for PrEP. It comes with an over label on it, and you just write the patient's name on, and then it goes to say take one dose or one tablet, whatever the instructions are. So it's readily available in the clinic. So once the patient comes, you're happy, that is suitable, all of that, then you can sort of write out, they can get the stock there and then to say, um, here you go, here's your prep. And then they just come back for regular reviews.
I see.
Instead of that would then stop them from going to a pharmacy, they might not have it. And just to avoid all these logistical issues.
I see. That makes sense. And I suppose if somebody were to go privately, then they would obviously they'd speak with, whichever healthcare provider that's doing their risk assessment. And then it would be a matter of then I'm assuming they would them a prescription and then they would have to go.
Yeah, so they probably would give a prescription. A lot of private clinics, depending on how big they are, they might have their own on-site pharmacy, so they can just go there. Or they can also try and get these pre-packs that I've just talked about, because there's nothing that stops them from getting it from a supplier, right? So I don't, to be honest, I don't really know how it works in the private sector, but I know that there's still some stigma around HIV and PrEP and PEP. So I don't think it would be the first preferred option, preferred choice to just give them a prescription which they can take to any pharmacy because, you know, the patient might not feel comfortable walking to different pharmacies and have you got this, have you got this, have you got this. I think they'd rather just prefer to get the drug there and then go and call it a day.
Yeah, no, I can understand that.
Yeah.
And I know we mentioned that prior to starting PrEP, people need a full kind of HIV or not HIV, STI workup. But then they also need, from my recollection, they also need, I think, their kidney and their liver function checked as well.
Yes, we do. That's something I should have talked about as well. Yes, mainly because of the tenofovir, because tenofovir, as great as it is as a drug in terms of reducing the risk of acquiring HIV or even treating HIV and reducing the viral load, it can cause renal toxicity. Um, so if a patient already has a poor renal function, then we'll be making a bad situation worse, and they wouldn't be eligible to have PrEP. The other thing is, well, if they have poor bone mineral density, essentially means if they've got brittle bones and they're at risk of, say, fractures or the risk of them getting osteoporosis is high, then that would be something to consider, and they may not be eligible for PrEP because, yes, we might stop HIV, but we also don't want you to crack your bones.
Yeah, yeah, it's all like risk benefit, right?
So that would be a discussion um, between the patient and the prescriber. You would have, as they say, shared clear decision making. But that's definitely something you would consider.
I see. And just so that, because people may not know, the people who see this, so PrEP is made up of two different medications. Is that right?
Yes, so PrEP is made up of tenofovir and emtricitabine,
Okay, and
and they essentially are from the same class, but it's they work because, like I said, antiretrovirals. Not retroviruses are quite adaptable, so you can easily build resistance to antiretrovirals. So I'm not as entirely sure why. I said no. I'm not entirely sure. I can understand the premise for using two drugs to increase the chances of them not acquiring HIV. But there are situations where you might only use one drug, but that would be a discussion between the clinician, and we have to weigh up the risk and the benefit. But in most patients, those two drugs.
I see. Okay. Okay. Awesome. And so I know we talked a little bit about the tests that need to happen before people start PrEP and how that might affect the clinician's decision in terms of the risk benefit. Can I ask? So, this is a question we get a lot. How is it that people are supposed to take PrEP? What is the correct way to do it? Because if you don't take it correctly, there's a chance that it won't work. And if it doesn't work, or if it's not going to be effective, and if it's not going to be effective, then people are unknowingly putting themselves at risk.
Mm-hmm. So there's two ways of taking it. This is something you would establish during the conversation. So the once a day we take every day, um, with no break, except if you're going to go through a phase where if we're going to be abstinent from sex for whatever reason, then there's no reason for you to keep taking it. But you take essentially once a day throughout the period where you feel like you're going to be at risk of acquiring HIV. And then there's what we call event-based PrEP. So those ones you only take around the event that can increase the risk of you acquiring HIV. So that would be two tablets, about 2 to 4 hours before we're meant to have sex, unprotected sex, so to speak, and then you take two more doses after the event. So you would take one 2 to 24 hours, and the next day you would take another dose, and then the day after that you would take another dose.
Okay, I see.
So that's event-based PrEP, and that might be more for say people who maybe they don't engage in unprotected sex all the time, but when they do, it's risky sex, so to speak. So um, they would only take it around that period, and then if they don't have sex for a period of time, then there's no need for them to continue taking it. But if somebody is at continuous continuous risk of acquiring HIV, so like a sex worker who works pretty much every night, then it would be more appropriate for her to take it every single day, as long as there's no other reasons why she can't take it. But say with a static, like, yep, it's fine, no problem, then yes, it'll be on every day.
Okay, I see. That's really, really interesting because I know that's something we often get. It's like, there are the people who take it once a day, but then I don't think everybody realizes that, with the event-based kind of schedule or dosing of PrEP, that it's actually, you said between 2 and 24 hours before the event?
So it's basically a 2-1-1, which involves taking two tablets 2 to 24 hours before engaging in sex,
Okay.
taking a single tablet 24 hours after the first two, and then another tablet 24 hours after that. So, which is what I explained before. So two was before the event. The next day you take one, and then the day after that you take one.
But that's really good to know because I think that's where a lot of people, again, they take it before and they think they're covered. They don't realize that they then need to take that single tablet, 24 hours after they've taken the first two, and then they have to take another tablet 24 hours after that. So it's just a matter of like reminding people that for it to be effective, they need to take it correctly. And so I guess, yeah. And I guess the other thing is like, if it is taken correctly, how effective is PrEP?
It's about 99%, because nothing's ever 100%. But yes, about 99% if they take it correctly.
Okay, that's really, really no. That's a game changer for people.
Mm-hmm.
That's really amazing. And can I ask, so with the continuous PrEP use, so people who are taking, one pill every day, I wasn't sure if it was one pill or two pills every day, but taking it every day because they have continuous ongoing high risk. If they stop taking PrEP, at what point are they does the medication stop working? Is it the day that they don't take it?
Essentially, when you take any medication, you get to what you call steady state. and the steady state is based on what they think is the half life of the drug, which is basically how long it takes for the body to break that drug down or goes down by 50%. And in theory, it takes 5.5 half lives to get to steady state. So we would have to go into the books really and see what the half life of the drug is, and how long it takes the body to clear to then be able to say um, to have a rough idea of when it would stop working. So it's very difficult for me to give you a definite answer at this point.
No, that's totally
So
fine. I appreciate it was more.
it depends really. So we have to go into look at the manuals and see what's in there.
Yeah. And can I ask, like, I know this is, again, this might be a bit more complicated, but if somebody misses a day, let's say they forgot their tablets at home or whatever, and then if they miss a day, what is their risk? Like, do they have to then do they take two tablets the next day to make up for it? Or do they just carry on and say, you've got to be on it daily for X number of days before we can, before it's deemed effective again?
So again, it would depend on if they were taking it every single day and how long they were taking it every single day for,
Yeah.
or
Okay.
if it's event-based prep.
Got you.
Now, if it's event, in all honesty, I'm not. This is probably this is a this. If I had this kind of scenario in reality, I would just go to the doctor and say, "What do you think we should do? Do we then switch to PEP for now,
To cover.
or would it be all right for them to just repeat starting the course? Because it also depends on what part of the regimen they missed. If they missed it, because essentially the two tablets is like a loading dose, so that you have enough um, within your body to prevent the virus from getting in, isn't it? And then the remaining two doses is to supplement the loading dose and to remain in your system for a certain period of time to combat the virus. So it depends at what point. So did they miss the two loading doses? If they missed the two loading doses, I think common sense would prevail, and we would just think, you know what, let's go for PrEP because you haven't even had it enough from the beginning anyway. If they missed one dose, then that's probably something I would discuss with the doctor and say, what do we do? Um, do we give PrEP, or do we just tell them to extend it? And also, is it just if it's because you have the two tablets, the one 24 hours and the one after that. So if they miss the last dose, again, we would think, do we just ask them to take one more, or do we do? So we would have to weigh up the situation. There probably is some sort of hard and fast rule from Bash and Beaver, because they have a lot of guidelines and fact sheets, but these guidelines are also like 100 pages, so I would have to dig through them to find the answer.
It's okay. Honestly, this was just also for my own because lots of times, like even though we have these protocols, it's amazing how many times people come in with like, where something changes or something has happened and trying to like adapt the protocol and understand like, how do we deviate from this? Like, how do we, and a lot of times, like you said, you err on the side of common sense and safety, and and it's all about just like mitigating risk.
Yeah, I mean, absolutely. But I think if anyone wasn't sure, um, if there was an element of doubt or there's a possibility that they could acquire the infection, I think most people would just move on to give the patient PEP, because prevention obviously is always better than cure.
Yeah, 100%. So prep is kind of amazing. It's changed the game. It's 99% effective if it's taken correctly. Are there any, I know you mentioned some of them, but are there any side effects of prep that patients or users might commonly experience?
So the main ones that we tend to worry about is the renal toxicity, but a lot of antiretrovirals have obviously side effects. Like any drug anyway, they have side effects. So
So the main
one that I think I've heard quite a lot is more sort of like the headaches, but that's usually like transient. So especially for those people who are taking it continuously, then eventually the body sort of like adapts to it, and then that sort of goes away. But the main things we tend to worry about, especially for those people who take it every day, would be like the kidney function, the liver function, the effect on their bones. Um, so those are the things we sort of worry about with prep, with the drugs that we use for prep anyway.
Okay. Well, that's good to know. And does PrEP interact with any other foods, drinks, medications? Is there anything that, people with other conditions who are taking something else, or,
Mhm.
is there anything that kind of stands out in your mind where you're like, actually, this is not somebody who should be taking PrEP if they're taking this medication, or if they're taking, is because some medications they interact with certain types of food or
Mm.
alcohol or things like that. Does anything come to mind with PrEP?
No, do you know what? Not at the top of my head, but that's because the reason I say that is because in clinic, um, we always check everything on the Liverpool HIV drug interaction checker. Even if they say to me, I take this herbal remedy, we would always go and check. And if it's not there, we'll still try and do some digging just to make sure that there's no interaction. So, right off the top of my head, I can't um, think of any drug that interact with PrEP. Um, and there probably is, but I just can't remember right now. But it's just more the conditions. So I think if there were other drugs that could make the kidney function worse, so we're thinking maybe
Some of the antihypertensive, so some of the blood pressure
yes, so
medications.
then we would probably then err on the side of caution. But it's not one of those um antiretroviral drugs. There are some where you know that they like what with the protease inhibitors, they have lots of interactions, and we would always like be worried about those. But I don't think the drugs we use for PrEP are one of those ones that have lots of interactions. But I honestly can't tell you any off the top of my head right now.
No, that's okay. But it sounds like in clinics, so anybody who would be prescribing PrEP has this HIV medication, interaction checker. You said so. Basically, so I'm guessing you guys enter any medications that individuals take, and then it makes sure that there's no cross reaction.
Yes, it's an excellent resource. So, if you just search Liverpool HIV drug interactions, you put the HIV regimen you want to prescribe, um, and then you put the other drugs that the patient is on, or the patient also intends to take, and then it checks, searches everything for you, and then it will tell you potential interaction if it's a weak interaction, if it's a strong interaction. It would also tell you the quality of evidence that they've used to make that decision. So, say strong evidence, weak evidence, it will tell you if it's clinical significance or if it's just theory. So, it might say, for example, with like metformin and tenofovir and emtricitabine, um, it might say, in theory, it might say it can affect the renal function, which can affect tenofovir, but in practice, blah blah blah. This is not usually something to worry about. So I've just made up that example, for example,
Yeah.
by the way. But it would always give you a very detailed answer. So it will tell you if you need to do anything about it and if you don't need to do anything about it. And that's usually what we go off when prescribing any HIV drugs with in a patient who takes other medication. There's also European AIDS Clinical Society called EACS, and they have this excellent table, and it then groups the different classes of the common classes of drugs
Mhm.
commonly prescribed with HIV drugs, and the impact or the effect of co-prescribing the two. So HRT would be a very good one. It doesn't. I don't think it really affects Truvada, prep, but say if it was a protease inhibitor or another drug that could assist that, then you would be worried how it would affect HRT. So it would tell you it increases the levels, it stays the same, it decreases, so on and so forth.
Okay. Oh, that's really interesting. That's
Mm.
a fantastic resource. This is where technology comes in handy.
And it's something that we tell other clinicians and other prescribers as well. So it might be the other way around. So you're prescribing another drug for another condition for a patient, and then they tell you that they're on HIV drugs. It's always worth checking, because the last thing you want is either for the HIV drug to cause the new drug to build up and cause side effects and problems, or for the new drug you're prescribing to reduce the levels of the antiretroviral and render it semi or fully ineffective.
Yeah, no, definitely. That's a fantastic tool
Mm,
for all clinicians to kind of be
mm,
aware of. So yeah, so it doesn't just have to be used in the sexual health setting. It can be used when you're
mhm.
starting any new drug, which is really interesting. Um, and I know we talked about this a little bit. We talked about, is there anyone for whom PrEP would not be appropriate? So I know we mentioned people who already have HIV, people who are at risk, who have brittle bones, who are at
Yeah.
risk of breaking bones because of the way that the drug works.
Mhm.
Um, People who have like reduced kidney function, basically, again, because of the way that the drug can affect the kidneys and the risk of that getting worse whilst taking PrEP.
Yeah.
Any other groups of people that stand out or come to the forefront where you're like, actually, this is
No, I think those are like the main people. The only thing to point out with the people with reduced kidney function, there is a limit. So um, it was anything above, say, 90, um, in terms of measuring their kidney function. Some people use creatine care and some people use EGFR, but anything above 90 EGFR is classed as good kidney function, isn't it? But then there are some people who are between, say, 60 and 90. So that's like mild, um, well, in hospital, we say renal impairment, but mild reduced kidney function for in simpler terms. So those patients will probably still be okay as long as you've looked at the bigger picture and there are no other factors that could cause that kidney function to decline um, as well. But if it was just mild kidney dysfunction, then you would probably still consider, on the basis that you would probably monitor the patient much closely, um, and you would also tell the patient that if at any point the kidney function drops considerably, then we would know that it's that drug and we would have to stop it. So you can still consider it in that patient. But any patient with an EGFR of say 60 and below, then no, we wouldn't. They wouldn't be suitable. I suppose you've mentioned all the other groups that I can think of. I think the only other thing that would be a cause for concern is how likely are they to stick to the therapy, even if it's event-based prep, either 211 or the continuous. If they live a very, very chaotic lifestyle and they're going to struggle um, to remember to take the tablets, then you probably wouldn't want to consider it, because in the long term they can get resistance, and if they do end up getting HIV down the road and they have resistance to that class of drug, you've ruled out that class of drugs completely. And we can't forget the fact that the drugs we use for primary and emtricitabine is one of the backbones, so to speak, one of the common combinations used for HIV. So you would sort of have to weigh up, the pros and cons. If you know they're not going to take it, then that might be a cause for concern. Or maybe you might say, okay, fine, you want it, but you need extra counseling and support to make sure that you do take it.
yeah, that it's taken correctly.
Mm,
Yeah, it is really important because resistance is such a problem with these
mhm,
medications. And so
mm,
trying to make sure that the individual who's taking it understands the importance of taking it correctly, not just for themselves, but also like,
wider
for
public, yeah.
exactly. Yeah, that's really, really important. And I think that's something a lot of people don't necessarily talk about or think about, but it is. It's really important. And then I guess finally, I know you mentioned undetectable, but do you want to just mention maybe a little bit about what that means and what U equals U means?
So U equals U essentially means undetectable equals untransmissible. So if somebody does have HIV and they're taking the treatment and they get to the point where the viral load drops to 50 copies per mil of blood or less, they're seen as undetectable. And once they get to that point, even if they did have condomless sex with somebody else, they won't be able to pass on that virus to the person they're having sex with. So, and this essentially is what drives the whole PrEP, and even antiretroviral therapy in general. So the idea is that first of all, we don't want people to get to the point where they get it. And then for those people who do get it, we want to give them treatment to make sure they get to that point where they can't pass it on to anyone else.
Yeah, that's amazing. And I think, again, that's something a lot of people don't know. If your HIV level or what we call it an HIV level, but if the number of copies in your blood is so low that it's undetectable on the test, it means that, it's untransmissible, so it can't be passed on. So I think with all the advancements that we're making in, preventative HIV care and then, ongoing kind of HIV care for those who tested positive, I think this has been one of the major breakthroughs in trying to get people to understand that is super important. So, yeah. Well, I mean, I know we've been talking for, like 40 minutes, but this has been so, so helpful. And so thank you so much for taking the time. I know we kind of mentioned PEP as well, but I feel like we've already been talking for 40 minutes, so I don't want to take up your whole day.
Well, maybe that would be maybe like another conversation. I mean, the premise of it is slightly similar to PrEP anyway. And the drugs we use for PrEP constitutes the regimen we use for PEP as well. It's just you add another drug to it. But I suppose that's another conversation for another day. The only thing I wanted to add was that if anyone wanted to sort of read up more or just learn more about PrEP and HIV in general, they're like good websites, simple to understand. Like you have things like AIDS Map, you have iBase, the Terence Higgins Trust, and they usually have very simple. I I want to say patient friendly, but not necessarily that they're patient. But when we say patient friendly, it means it's very simplistic, so that everybody can understand. And usually, if you're not even sure about this website, you just type your question into Google. Um, iBase, ASMAP, one of the Terence Higgins, they probably have an answer to the question, and there will be a link for you to follow to go and read up on it. Or obviously, there's always endless choices for you to search your local sexual health clinic.
For sure. I think there are some great resources out there. It's just knowing which ones people should use and go to, because there's just
so there's the ones with all the jargons.
Yes. I know. Some of them are really medical. And even me, as I'm reading through, like, I'm like, oh my, they use all the acronyms. And I'm like, hold on, what did that one mean again? And so it's about finding, I guess, information that's evidence-based and like from a reputable source. So from a source you can trust, but also that explains it in a clear enough way and in a simple enough way that like anybody who's reading can understand it. But Christiana, thank you so, so much for taking the time to chat to me today. It was super helpful. I know I learned some stuff as well, which was cool. Yeah, and hopefully we can do this again. Yeah, thank you again.
Thank you for having me.
You've been awesome. Like, you were great at it, like, one, talking on camera, but two, also just like chatting through your thought process and what things are. Because I think sometimes a lot of people have that information in their mind, but they're not very good at like explaining it. But you did an awesome job. So
thank you.
Thank you. I hope you enjoy the rest of your day.
And you too.
Yeah.
Take care.
Take care. Bye.